Good afternoon. Today I'll be talking about RSV prevention in neonates, a really exciting subject with a lot happening. My name is Natalie Mazur, and I'm working at the Wilhelmina Children's Hospital as a pediatric resident and researcher. I'd like to start with a picture of Walden Pond from my hometown, because there was a philosopher, Henry David Thoreau, who lived there in the woods for 2 years, who had a beautiful quote: "We must look a long time before we could see." So for him, this was about nature, but I think it's also very relevant to the field of monoclonal antibodies against RSV. This is my conflict of interest slide. So there are several populations for which RSV prevention is important. Today, I'll focus solely on infants, but we recently also know that for elderly individuals, RSV has an even bigger burden than influenza. And for me, the bottom is most important, the global population, because we know that most of the mortality due to RSV actually occurs in the developing world. And I'd like to start with a quick video we made a few years ago that puts a face to the numbers of RSV.
I was pregnant with Ramondre 2016, and he did pass away when he was 3 months and a few days. He was a healthy baby, always smiling. I never took him to a clinic or a doctor, but then he started to struggle to breathe heavy.
So what I understand about RSV is that it's a virus, okay, which causes a respiratory infection in everyone, in adults and children. But in children it's quite severe.
When I came there, they told me, "Okay, come in, mommy, there's lying there." And he was lying so peacefully, like he was sleeping. And then I picked him up and I told him, "Lamondre is mommy. Wake up, baby." And then he didn't want to wake up. The other mummies who is pregnant and who is wishing to become pregnant, they must all know about the RSV, because I didn't know. And if I would have known about it, maybe I would have done something or take him earlier to hospital, maybe he would have still be alive.
So it's always very hard to follow up this video, but hopefully it gives a context, and specifically a patient context, to the epidemiology of RSV and why this is an important field. So I always use the rule of tens when I talk about RSV epidemiology. So every child gets RSV infection, and 10% of those children get a lower respiratory tract infection, bronchiolitis or pneumonia. And 10% of that population, so 1% overall, is hospitalized with RSV. And then 0.1% ends up with respiratory failure in the intensive care unit. This is for developing countries. And we know that certain populations, like preterm infants, infants with bronchopulmonary dysplasia, congenital heart disease, Down syndrome, are at highest risk of severe disease. However, as you can see at the bottom, the majority, so almost 4 out of 5 infants, are actually healthy term and have none of these risk factors and still get severe RSV. Recently, we did a very large prospective study, the rescue study, in 5 countries in Europe to look at the rates of RSV inside and outside of the hospital. And we found that almost a third of children get any RSV, about 15% medically attended RSV, and 1.8%, so even higher than I just showed, are hospitalized, which means that 1 in every 56 infants in Europe is hospitalized with RSV, really an astounding number. And as I said, who gets severe disease, we really don't completely understand. We know a lot of risk factors for this severe disease. You can see this beautiful figure here, where there are both factors that the child may have, exposure factors, immune factors, and you can see also still a lot of open questions about factors specific to the pathogen themselves that were unclear whether they may predispose to more severe RSV disease. So still a lot to understand, a lot of gaps in knowledge. And today I can't talk about RSV prevention without quickly zooming out to the RSV vaccine landscape. It's really a booming area. Unfortunately, almost all candidates in development, which you can see here in this figure, are in development for high-income countries. There are 5 different approaches being used, several for infants, others for elderly, others for mothers to protect their infants. And today I'll focus solely on the monoclonal landscape, though there are some really exciting developments for maternal vaccination. And here again, you can see the 3 different main populations for prevention. And I will focus on the top layer, so phase 3 for infants, which actually boils down to, as you can see here, the monoclonal approach, so the prophylaxis. And the RSV vaccine landscape has a long history of many failed candidates, but I want to really emphasize that now is a really exciting time where there are many candidates in phase 3, as you can see, and some with expected registration very soon, which I'll talk more about later. So I'd like to start with the problem. So for a long time, monoclonals have been thought of as the magic bullet for prevention of infectious disease. And the reason, as you can see here at the top, is that they can be highly specific, or the most highly specific, engineered to be highly specific to a certain antigen. And I'd like to talk about 2 candidates which were already registered for RSV prevention. One, you may remember, Respigam, which was a hyper-enriched IgG and worked fairly well to prevent infection in infants, and palivizumab, which is still on the market, which is a monoclonal against a non-human target, the F protein of RSV, and has been registered for more than 20 years. But unfortunately, in the LMIC context, it has been barely or not available at all due to high costs. We do know resistance is very low and that it's very safe, and it protects against about 50 to 80% of hospitalizations in infants. So you may think, well, there's a solution. So why is this a problem? Because we have RSV prevention. Well, it's far from ideal. So the duration of protection is short, about a month, which means that in the season of RSV circulation, you need monthly injections to ensure protection. The neutralizing capacity is not optimal, as we've learned, which may translate to efficacy or lower efficacy. And finally, it's very expensive. So in the Netherlands, it costs 100,000 euros to prevent 1 hospitalization, which is the reason that it's largely not available in LMICs up to this point. There have been several other monoclonals developed. One is modavizumab, a 2nd generation version of palivizumab with a much higher neutralizing capacity, but it was trashed after phase 3 because of a 2% higher hypersensitivity reaction in the intervention arm. And subtavimab, a Site 5 antibody, which was also stopped in development in phase 3 because, as you can see on the right, there were resistance mutations in the RSV-B strain, which was what we think the reason for lack of efficacy. So several near misses. And most exciting is that we've really learned a lot about RSV. So it has 11 genes and 10 proteins, 2 important ones on the surface for monoclonals, the F and G protein. And here we show viral fusion. So G is important in attachment to airway epithelial cells, and F facilitates fusion into the cell and on its way to viral replication. And there are 2 different types of RSV you can almost think of. The pre-fusion on the left, which is much more red because it has much more pre-fusion F protein, and post-fusion F protein is much more prevalent on the viral capsid after fusion. And this is really one of the key slides of this presentation. So in 2013, the pre-fusion F protein was stabilized for the first time, and that gave us insight into the different epitopes on the pre-fusion protein, and specifically epitopes that only exist on pre-fusion, so site 0 and site 5, as you can see, and have much higher neutralizing capacity than other epitopes. So site 2, for example, is on both and is the target of palivizumab. And these were key insights for better prevention. So so one of the most exciting developments, as I think you may have all heard, is an extended half-life monoclonal nirsevimab, a site 0 pre-fusion monoclonal, which was approved in November of 2022. So on the top, you can see that it has 150-fold higher neutralization capacity than palivizumab. On the right are the results of a trial in preterm infants, in which we saw 70% efficacy against medically attended RSV and 80% against hospitalization. And recently published on the left bottom is the efficacy in also term infants, which was 75% against medically attended RSV. So this is super exciting because it would mean that with one injection, you can protect every child, so not just high-risk individuals, against RSV. However, this will largely again be in the developed world because of high costs. There's some other candidates in development. So clesrovimab, which is a site 5 antibody, also favoring pre-fusion F, which has a much higher potency than palivizumab, neutralizing potency, and RSMO1, which is also a site 0 monoclonal, which is specifically being developed for the developing world, with the goal of a really low cost intervention. And this is currently entering phase 2. So to summarize, monoclonals have the potential to be highly targeted interventions against RSV, but there is still a lot of work to do. So there are exciting interventions such as nirsevimab, which are about to reach the market, but probably won't reach areas where the burden is highest. Resistance will be an important thing to monitor, and potentially a drug cocktail of multiple monoclonals will be needed in the future. Local administration is an exciting new area to look at to prevent RSV disease. And finally, price of the monoclonal is the most important factor in ensuring access in the developing world. Thank you.